I found Londa Rukhadze from the Tbilisi State Medical University with the National Cancer Screening Programs, the case of Georgia, to interrupt this discussion about pain. Londa Rukhadze. She was number 15.
Yes.
So we decided here, but we have several centers of management. They have a different list.
Good morning. My name is Londa Rukhadze. I came from Tbilisi State Medical University, and I'm going to present national cancer screening programs in Georgia. Non-communicable diseases are now responsible for the global deaths, and cancer is expected to rank as the first leading cause of death. According to estimates from the World Health Organization in 2015, cancer is the first or second leading cause of death in 91 of 172 countries, and it ranks as third or fourth in an additional 22 countries. This figure shows the 10 top cancer types worldwide for estimated cases and deaths. For both sexes, lung cancer is the most commonly diagnosed cancer and the leading cause of death, closely followed by breast cancer, colorectal cancer, and prostate cancer for incidence, colorectal, stomach, and liver cancers for mortality. For men, lung cancer is the most commonly diagnosed cancer and the leading cause of cancer death, followed by prostate and colorectal cancer for incidence and liver and stomach cancer for mortality. Among females, breast cancer is the most commonly diagnosed cancer and the leading cause of death, followed by colorectal and lung cancer for incidence and lung and colorectal cancer for mortality. Regarding to cervical cancer, it ranks as 4 for both incidence and mortality. According to population-based cancer registry in Georgia, which was implemented in 2015, January 1st, breast cancer is the most prevalent cancer in women. The incidence rate of breast cancer per 100,000 women decreased in 2017 compared to the incidence rate in 2015. It was 97.5 in 2015 and 79.6 in 2017. Regarding the colorectal cancer, the incidence rate of colorectal cancer per 100,000 women decreased by 1/3. It was 23.1 and it is 16.1 in 2017. Now, regarding to cervical cancer, the incidence rate of cervical cancer per 100,000 women decreased dramatically in 2017. The incidence rate was 19.4 in 2015 and 14.3 in 2017. New cases of breast cancer are more prevalent in women aged 50-70 years old. New cases of cervical cancer are more prevalent in women aged between 60-65 years old. And new cases of cervical cancer are more prevalent in women aged 40-60 years old. According to population-based cancer registry in Georgia, lung cancer is the most prevalent cancer in men. Regarding to prostate cancer, the incidence of prostate cancer per 100,000 men decreased by 41%. In 2015, it was 29.5, and in 2017, it is 17.4. Regarding to colorectal cancer, after a slight increase of incidence rate in 2016, it decreased again, and it is 18.8 in 2017. Okay. Prostate cancer cases are more prevalent in men aged above 60-65 years old, and new cases of colorectal cancer are more prevalent in men aged 60-65 years old. Regarding to age-specific incidence rate per 100,000 for localization cancer in both gender, the highest incidence rates were observed in men aged above 65 years old, and in women it starts increasing in aged above 30 and increases dramatically as age increases. The objective of cancer screening is to identify asymptomatic population who have precancerous lesions, so the treatment can start early to reduce morbidity and mortality. Population-based national screening programs were implemented in Georgia in 2011. For breast cancer, the target population is women aged 40-70 years, and the screening is done every 2 years. For cervical cancer, women aged 25-60 years, and the screening is done every 3 years. Colorectal cancer is done in both gender, aged 50-70 years annually, and prostate cancer management is conducted in men aged 50-70 years annually. For breast cancer screening, target population is screened by mammography, clinical breast examination, and ultrasound if needed. If malignant process is not presented, then the patient is routinely recalled. If the malignant process is presented, then the patient is referred to oncology unit. For cervical cancer screening, target population is screened by using the pap testing, colposcopy and colposcopy with biopsy if needed. If the result is negative, then the patient is routinely recalled after 3 years. And if the result is inadequate, then the test should be done again. And if we get the pap test abnormal, then we do colposcopy or colposcopy with biopsy. And if the diagnosis is confirmed, we send the patient to oncology unit. For colorectal cancer screening, target population is screened by fecal occult blood test, colonoscopy or colonoscopy with biopsy if needed. If the test result is normal, then the patient is routinely recalled. If not, we do colonoscopy or colonoscopy with biopsy. And if the diagnosis is confirmed, we send the patient to oncology unit. For prostate cancer management is done in target population by identification of specific antigens in blood. If the test is normal, then the patient is routinely recalled. If it is up to threshold, then we refer to oncology unit. This slide represents the coverage rates of each cancer by population. For breast cancer, coverage rate of breast cancer screening is 18% in Tbilisi, in capital, and 9.2% in regions, while in Finland is 80%, Sweden 81%. For cervical cancer, the coverage rate is 18%, and in regions 11.1%, while in developed countries mean range is 63%. And colorectal cancer coverage rate is 3% and 1.6% in regions, while in Turkey is 30% and Montenegro 33%, and prostate cancer management is 5% in Tbilisi and 3.3% in regions. So since the coverage rates are very low in Georgia, we need to increase the role of primary health providers and family doctors in raising the population awareness about screening programs, planning and implementing media campaigns aiming at raising population awareness to eliminate asymmetries between regions with regard to organized screening, promotion of organized screenings in regions with low coverage, and we plan to conduct the quantitative and qualitative studies to identify variables that lead low participation. Thank you for your attention.
Thank you very much for this interesting presentation. Please, questions. Okay, we have Associated Professor Slivka, the member of the jury.
Thank you. I would like to ask you about, can you suggest any ways how to improve the coverage with this screening program in rural areas?
We need to raise population awareness. We can use media campaigns, advertisements, for example, by TV, and also we plan in 2020 to conduct study to find these people, these women, for example, or men, what kind of people don't do screening exactly, like can be people with low education, for example, can be obesity, for example. And the important is that people don't know the concept of screening. They think, okay, I don't have any symptoms, so why I should go to the doctor. So we need to tell them this, that they don't need to be really sick to go to a doctor. They can be healthy and go and check. And it's completely free of charge.
Thank you.
And
Thank you very much.
do I have some seconds to, I would like to thank to my university, to Tbilisi State Medical University, to support me to come here. And I also want to thank to Bukovina State Medical University to invite me. It's a very big pleasure to be here. And also I'd like to thank to people who organized this Congress. So I'm happy.
Thank you very much. This is a little bit unexpected. More questions? Oh, just as fast as possible.
Yes. It's the same.
Okay, thank you very much.